My name is Chris Denson. I am the Director of Policy and Research for the Georgia Public Policy Foundation. We're a nonprofit think tank located in Atlanta, focused on state policy issues. And I'm here today to present on the report that we published in April of this year, and which we examined the history and the economic impact of certificate of need laws in the state of Georgia. And I'm just going to walk you through the report, do a brief overview. Everyone should have a copy of it in front of them, along with two handouts that I've inserted in there that I'll explain both as this process is going on. And, this is a subject, Chairman Parrish mentioned the history of the subject, and it seems to be continually ongoing. Of course, both our neighbors, North Carolina and South Carolina, have enacted CON reforms since the publication of this document. I know that the presenter from NCSL spoke about this a little bit at the last meeting, but there's some other things as well I'd like to highlight in relation to Georgia. But anyway, so let me get started here. And so, the overview, or what we look, sorry, my apologies. This is a tight fit here for paper documents. So we wanted to look at the issues surrounding cost, access, and quality of healthcare as it relates to CON. And so my co-author and I, Dr. Matthew Mitchell, who's an economist that's affiliated with West Virginia University, he takes a regular look at the existing academic research around CON. And so if you later on in the study, I'll provide a brief overview. We've summarized those studies, what they show regarding healthcare spending, access, quality, the ability for underserved populations to access healthcare in states with and without CON, underserved populations being traditionally those in economically depressed areas or ones that have provider shortages. And so with that, I'll get started. As Chairman Parrish noted, I'm going to skip over the legislative history here in Georgia, but if you go to page 9, we did summarize all of those reforms since CON's enactment in the state, the year, what was done to traditionally, in almost every instance, lessen the CON regulations that the state currently had in place. And so you'll see here, even in that setting, we've included what previous speakers have mentioned those committees, including a Georgia State report going back to 2005, when Governor Perdue established the commission. And if we just want to make it an easy access point for anyone that wants to go back and look at the history and the evolution of CON laws in the state of Georgia at that time. On page 12, we've outlined what it takes to receive a certificate of need in Georgia, the process through which you go through the Department of Community Health. I know you heard from DCH at the last meeting, so I won't go through that. This is where I do want to, and we listed obviously here every service that requires a CON in the state of Georgia. But this is where I want to reference my first handout. I had the opportunity to speak at an event that the Atlanta Regional Commission hosted a few weeks back, in which they looked at healthcare disparities resulting from the closure of the two Wellstar hospitals in South Fulton. And if you'll notice here, and I apologize, it was supposed to print in color, but it's here in shades of black and white. But if you look at where behavioral health and urgent care enter the patient care continuum spectrum, there are 14 different services that were impacted by the closure of those two hospitals. Of those services, 11 of those require a certificate of need. So that's something to think about whenever we think about, okay, a hospital is closed and we need to replace those services. This is what we need to do in terms of allowing for replacement, whether it's a single individual hospital or a multitude of facilities or services that will do that. But I was speaking with Dr. Rochelle afterwards, and she's the chief health officer for Fulton County, and she'll give me permission to share that slide with y'all today. I know at the last hearing, there was some discussion surrounding the application process to receive a certificate of need at the state. My team and we researched every application from 2017 to 2022, As you'll see there, that was nearly 380 certificate of need applications. When we went to publication, 43 of those were still outstanding. But of those we reviewed, we found that when there is an objection to a certificate of need application at the state level, the odds of denial more than double from 20% to about 50%. Every additional party, so in some cases when you have opposition to a CON application, that increases the odds of denial by roughly 11% with each opposition that is proposed to a CON application. An opposition that's filed to a CON application adds 234 days to the wait time. But if it's specifically a competitor opposition, that adds 520 days to the wait time. Each additional party on top of that adds another 129 days. And then here are these last 2 points that we found in our research. The cost of the project is not statistically significantly related to either approval or wait time. So when we think about what type of project it is that the application is for, there was no bearing in terms of cost on the approval process. And then there was not any statistically significant trends in either approval or wait time in the overall process. So what we wanted to do was just provide an outline there of the complexity and the duration of time that is required when a CON application process is begun, especially as we look at closures, evolution of healthcare technology, and how do we move forward in ensuring healthcare access in our communities. One thing that I know many members of this committee have looked at, many deal with this in their own communities, is what is the impact of certificate of need laws on safety net hospitals? And so, we often hear this argument that CON is needed to protect hospitals, most specifically in terms of elective surgeries and imaging, the two revenue generating service lines. And so, the CON should be needed for their protection and sustainability for these safety net hospitals, which are most often in rural areas. And so for this study, we examined Florida, which repealed CON laws for everything but specialty hospitals and long-term care facilities in 2019. And during that time, they have announced 64 ambulatory surgery centers opening, where elective outpatient surgeries are held. And in that area, 63 of those were located in urban counties. Only one of those actually operated and located in a rural county. The full appendix of those openings is in the back. But what's interesting about that one rural county, it was actually a joint venture between the local hospital in Florida and a physician group. And then there was another physician group in a neighboring county that announced their own plans to open an ASC. So we did see this kind of add-on effect of providers were coming to this area. But that's just, I think, instructive for when you think about the safety net hospitals and where these elective surgery centers might be located. On page 17, you'll see a chart that we compiled. I believe we now have 13 states since South Carolina that have repealed their certificate of need laws for nearly everything. And that chart there in front of you compares Georgia to similar states on page 17 in terms of population. So they're ranked by population, but also by the percentage of rural population as well. And so we use the documentation provided by the Shep Center at North Carolina, compiled since 2005 to look at rural hospital closures. And what you'll see there is we've actually, the two states that are most geographically similar to Georgia, the state most geographically similar to Georgia, North Carolina, actually has a CON for hospitals and ambulatory surgery centers, and has had the most rural hospital closures in the time period we examined. And so that's just another data point when looking at the impact of CON on safety net hospitals and what it means if we have a CON law and the ability to sustain our rural safety net providers. On page 18, we move into the summary of the academic research. As I mentioned, we looked at spending, we looked at access, we looked at quality, and we looked at underserved populations. If you look there, there's tables that summarize the data and the research in there. And in the back as well, we also have an appendix that, cites every study we've looked at in case you want to do a deep dive into that. But what you'll overall see there is that, for example, on spending, that CON is 60% of tests we examined was associated with worse spending outcomes. That's on page 22 that summarizes the spending data, that table. When it comes to access, 82% of the studies we examined associated CON with diminished availability and access to healthcare services. Moving forward to quality, you'll see that 55% of the tests that we examined associated CON with diminished quality of services. And that looks at not just like the output of the surgery or the healthcare procedure, but also things such as acquired infections as well, and other associated bad healthcare outcomes during the healthcare procedure. And then the section 4 on page 28 for testing underserved populations, 80% of the tests we examined were associated CON laws with worse outcomes for underserved populations. And if you think about it, I think everyone in this room would acknowledge when we consider underserved populations, they're typically associated with a lower percentage or lower proportion of commercially insured patients. All healthcare providers subsist off commercially insured patients. And so if there already a lower proportion of profit margin to be had in these areas, it makes sense. Why don't we add a more expensive and a more timely process for any potential provider to locate in this area? And so that's what the research has shown us in terms of like allowing for CON to and why it's limited the ability of providers to open in some, or the want of some of these providers to open in these areas with underserved populations. I'd mentioned earlier, there's another handout you should have in there in front of you, and that is the millage rate handout that's created by the Georgia Department of Revenue. I provided that for the committee. I know in this year, the House Health and Human Services Committee, when they had testimony for SB 99, which is the rural hospital CON bill, there were some concerns expressed by the committee members regarding if there was a lessening or repeal of CON laws, what would the impact be for those counties that are currently on the hook financially for the existing facilities? That's a 44-page document. I have dialed it back here to the 10 known health facilities that are receiving funding. The one caveat with that is, in my research on authorities, I know that some counties use the development authority to fund their local hospital. I don't have a comprehensive list of that. So this is just the ones here that I know where they've explicitly stated they are funding the hospital. And you'll see here we have the one county, Habersham, that is currently using a bond to pay for that facility. But that document came straight from the Department of Revenue. And the other thing I wanted to address today is, I mentioned earlier some of our neighboring states. Of course, South Carolina this year moved to repeal CON for everything but long-term care facilities. North Carolina scaled back their certificate of need laws. They repealed CON effective immediately for psychiatric beds and rehab facilities, and they increased their monetary thresholds for long-term care facilities that are currently located on site at a healthcare facility. They also increased the monetary thresholds for replacing their equipment and for diagnostic centers. I will say that the unique thing about that, from what I can understand about North Carolina, whereas actually we allow that DCH to unilaterally raise those limits, it appears that North Carolina does that legislatively. So it's not a true like for like. Interestingly enough, in 2 years, they will remove ambulatory surgery centers from CON for any county over 125,000 people. That is 23 counties in the state of North Carolina. Those ASCs will have a 4% charity care commitment, similar to what we currently have in Georgia under our LNR process for a single specialty ambulatory surgery center. In 3 years, they'll remove MRI requirements from CON for those counties over 125,000 people. Now in Georgia, using the most recent census, we have 19 counties that would qualify over at the 125,000 person threshold. And just for context, the dividing line around 125 is I believe that Clark County would actually be the last county above 125,000 people. Carroll County would be the first one below that threshold, to kind of give you an idea for what that would mean in the state if you did institute a population threshold. Tennessee has also favored the population threshold for imaging services. In 2021, they instituted that same requirement for imaging centers. They did a much more kind of narrowly tailored theirs to go after Knoxville, Memphis, Chattanooga, Nashville, and a suburban county that also had the population threshold. So our two neighbors to the north are fond of using the population marker as well. And, you know, that was just some additional things that have come up here during the process as we all discover this. You know, there's a lot of information there in front of you today. I know that as Chairman Parrish outlined earlier, you have a mandate to go forth and put, you know, recommendations to ensure Georgia stays. You know, we remain a state with good and equal access to health care. And so I hope that the report, my summary of it, has provided, you know, a little bit of insight into the current environment here in the state of Georgia. And with that, I'm happy to take any questions that the committee may have.
Good. Thank you, Chris. A lot of information there. Any members of the committee? Dr. Rice.
Thank you, Chris, for your presentation. Very good information. I just want to add a friendly amendment to your handout. This was a handout that was actually created through our work with Fulton County, and it was meant to be a representation of what the ideal state would look like if we were meeting patients where they needed to be cared for. It does not actually represent the services that were accessible through WellStar. That would have been an ideal state if it happened. But this is what we put together from listening to our focus groups, our community engagement, to say where are people mostly having need, and what type of services could be created in multiple settings and in multiple modalities to actually utilize hospitals only when needed, so that that is not the place where people are receiving care that could be done in an ambulatory setting. So that's what this was meant to represent. So that footnote probably needs to be changed. Thank you.
Yes, thank you for that, Dr. Rice. I just use that as an example of, I think when we have this discussion, so many people that I speak with, at least their minds immediately go to a CON is for a hospital, and they don't recognize the extent of CON requirements for these services. And so when I was speaking with that room of folks that the ARC put together, they were really shocked that of those 14 services that are highlighted beginning in the continuum of care, that 11 of those would require a certificate of need in the state of Georgia.
I definitely think it gives the committee something to think about if we're going to be thinking about access to care and meeting the patients where they are, right, in the community, because that will reflect in impact cost and also convenience, and also the experience that the patient will have. And so I definitely think it can definitely give us to think about something to think about as a representative of an ideal state.
Yes, ma'am. Thank you.
Thank you, Chris. Thank you for your presentation and y'all's work on this. And I did notice a lot of the studies, this is an observation and then a question. A lot of studies, because of the lack of information about what's the difference between a CON and a non-CON. Some non-CONs have a moratorium, we found out last time, which is even more aggressive than a certificate of need process. But there's some association factors that go on that seem to say, well, this state has CON and these things happened, or this state doesn't have CON and these bad things didn't happen, or, you know, so I appreciate the fact that y'all put footnotes at the end, because there's a lot of this that's more association. I mean, a hospital could have fewer closures like in Ohio, but it may be that they expanded the payment rate for OB and pediatrics, like we've tried to do sometimes in Georgia. Just a quick observation, and the population issue is kind of an interesting one, as you say, our two northern neighbors have used. One of the things I've noticed is most of us would like our family member, ourselves, to go to a center of excellence, whether it's for hip replacement or pediatrics, cardiac care, women's care, whatever. More and more people are more willing to travel a little bit to go cancer care, for example. How do you deal with the fact that, especially with a full-fledged hospital, it takes a certain amount of heft to have enough beds to do great cardiac care, great cancer care, great OB care, pediatric care. It's kind of interesting. There is whereas for urgent care, you can split it up, or even imaging in particular with very little risk, you can split it up into small, one of each of the four main machines, ultrasound, CT, MRI. You can set those up a lot of places without sacrificing quality, but more and more in healthcare, we're realizing that you need a certain number for your team to do every year.
Yeah.
How do you see the population level as an advantage? Maybe that model of recognizing the population is what's needed?
Well, I think that's a multi-layered question, Dr. Newton. So obviously for just a pure sustainability, there has to be a minimum number of patients that come through the door every year. And one thing, and my colleague, Dr. Mitchell, is much more versed in this than I am, but it would stand to reckon that if CON was operating as in its best theoretical model, for example, you have a captive population, and this particular set of surgeons they're getting all of the reps. But that is not actually what the research, the majority of research has shown in terms of quality. I think too, one thing that we're getting at when it comes to the safety net hospitals is it economically possible for a multi-specialty surgery center to open in so many of our cities and towns across rural Georgia, and just economically, that's just not feasible for them. And so that when I often have this discussion, that is a much more, it often goes in a different direction. I know this committee, the other body that's examining CON in the Senate, like there's been some back and forth on what exactly the directed payment program is. We don't seem to have a consensus answer on that. So I don't want to dive too much into that, but I think you're right in that both, if you look at it as state by state comparison, as well as even comparing it regionally across Georgia and county to county, for example, it's tough to just have this one size fits all answer for a lot of the issues you're speaking about there.
Well, thank you.
And that's the reason why we provided a number of states, because I've spoken with folks that want to know what Texas did. Texas repealed CON in 1985, and I can talk to 10 different people and get 5 different answers on what happened in Texas. Same thing goes for Carolina. And so that's why I used Florida specifically for the ASC example, just because it's a neighboring state and it's the one that's done it in a recent enough timeline to where we can examine kind of what this healthcare, let's just say post-Affordable Care Act healthcare environment is. And that provides probably the best data set I could come up with as a pure anecdotal comparison.
Thank you, Mr. Chairman. I have a question around sort of implication of your underserved populations.
Mm-hmm.
It seemed to me that you were saying, and correct me if I'm wrong, that by eliminating CON, the supply would go up. Potentially supply would go up for providers in those areas, therefore increasing the ability for people in underserved areas to access healthcare. Is that what you were saying?
When you're saying the limiting goes up, what do you mean by that?
So meaning that sort of in underserved areas, if you have the ability to put an ambulatory surgical center in some of these places, or whatever that demand is that somehow by eliminating CON, I wasn't sure if you were saying this or not, by eliminating CON, you would increase the supply of providers.
Yes, sir. So,
and that would, help out that population.
So I'll say this, if you're talking about an area that is, we'll just say 95% commercially insured, I think providers would be willing to endure the time and the cost to undergo the CON application process. If you're talking about an area that has 15 to 20% Medicaid, 10 to 15% indigent underserved, let's just say 40% Medicare, that very quickly becomes a proposition to where if you're a provider and you're looking to locate in an area, you say to yourself, do I want to undergo the CON process, both in time and in money? If I know at the end of the day, my profit is, I'm already going to be teetering on the black or the right below in the red in terms of a profit margin to survive and remain open.
Yeah, it does. And so I have a secondary question because when I think about it from an economic standpoint, it is like, you sort of have you enter into this place of factor immobility.
Mhm.
And so when you start thinking about factor immobility, changing the production doesn't necessarily increase the quality or the service. Right. So we could change literally how we produce healthcare for folk in these underserved areas. It doesn't necessarily mean they'll be able to access it. And so I guess where I'm struggling is, how does CON, whether we keep it or we don't keep it, how does it actually increase accessibility in underserved areas?
Well, I think it's just the barrier to entry. And so that's two things. That's one is the economic discussion we were just having. But on the other hand, too, if the state, for example, denies a CON, you're effectively creating a monopoly in certain regions around the state. I live in, I guess it'd be an exurb would be the technical term for it. But we only have one provider. And I went through an elective surgery recently. I had one provider to choose from in my area. And we have good jobs, good commercial insurance in that area. But still, I was limited to one choice. And so I think at its base concept, that's where the access comes from in CON. We didn't get into things like, I know that Ms. Chubb with the Augusta Birth Center is going after me today. We'll probably talk about some of the implications of what's known as the competitor's veto. But I think at just the base level, we're creating a high barrier to entry for a lot of these healthcare providers that do want to enter in at their community and provide a service. And I think the point about immobility is a great one, because a lot of these philanthropically oriented providers, I often cite the example. I had a physician's office manager reach out to me about a year ago at this point. They were considering putting an MRI machine in their office. The hospital and they were going to do cash pay rate because they serve a mostly immigrant population, and they wanted to have a cash pay MRI. But they knew the hospital down the road from them charged 7 times the cash pay rate. They just said, look, we know we can never get it. One, if we don't want to endure the CON process because we know that they have advantages we don't. They ultimately end up hiring a radiologist, nurse techs, and got around the CON process that way. But I think there are a lot of providers that, especially as healthcare technology advances, that's worth considering, like their barrier to entry. One thing that's really come to mind as I was doing the research for this, I was unaware of. Cardiologists are not eligible for a single specialty LNR. And Medicare since 2008 has approved having pacemakers and other rhythmic devices inserted in the outpatient setting. So I think it's just, there's obviously the big concepts, the survival of hospitals and this kind of equity of having to see everyone that we often debate. But there are smaller providers in this process that I think we often forget about. And quite frankly, they choose not to undergo the CON process because they understand it to be arduous, both from their own personal experience or what they hear from colleagues around the state.
Dr. Rice.
Chris, in this study, when you all looked at North Carolina with the ambulatory surgical centers, and you said they had a threshold of 4% charity care.
Yes, ma'am.
How was that established, and did it make a difference, or does it make a difference of what percentage of charity care they are required to meet to enhance access? I assume that's why they were doing it.
Yes, ma'am. And so that actually is not in the report. That was part of their 2023 legislative package. They came out after we had written this study. But yes, they had established in code, and much like we have in code here in Georgia, we have a similar charity care requirement. And so I would leave that to the hospitals and ambulatory surgery centers to debate the efficacy of that such requirement. But we do have a similar statute currently in Georgia.
Any other questions? Scott? Yeah.
Chris, thank you for being here. Just a question of clarification. Back to the Florida ASC information in your report. I want to make sure that I'm understanding what you're saying. I believe that we're talking from July 19 to 11/22. You're saying that there were 64 new ASCs in the state of Florida as a result of the elimination of CON. And am I right that those are reflected in the back of the report on pages 40 and 41?
Yes, sir. Those are the ASC developments announced, and that is in the appendix in the back, along with each of those studies that we cited for the summary of the research.
And just so I'm clear, the the start date of the CONs that you're suggesting are in the date reported column by the ASCs. Is
Yes,
that
sir.
accurate?
That's correct. And we chose the date after the CON. There were, it's reflected in the chart there, the immediate number, but I mean, you'll see that I believe we actually did have some in the immediate aftermath of the CON repeal announcement.
Okay, thank you.
Yeah, Dr. Hawkins.
Yeah, I was looking at your quality section there on page 26, 27, and 28. Yeah, I know it's hard to measure quality, especially when you look at ASCs. And realize, like my experience on April 24th, I was supposed to have a knee replacement. I was IV'd on a gurney. Surgeon already marked my knee up. I'm going in and the anesthesiologist stops us in the hall and says, I won't do you without an arc line because of stenosis, I have aortic stenosis. My point is that if you pick the healthiest people and do them in ASCs, they have really good results. And if you pull the healthiest people out of the hospitals, their results start going downhill because they're treating sicker people. So I hope at the end or somewhere along the way, there's a concentration on that. Because I think healthcare outcomes really depends on the information coming in with the results you get out, you know?
Yes, sir. And we tried to account for those variables as much as possible, but at the end of the day, you're absolutely right. There's the quote that often goes around, and I'm, sure Dr. Newton's heard this till he's blue in the face going back to medical school, but medicine is more of an art than a science. And so you're absolutely right. So we try to control for that as much as possible, but at the end of the day, we're just summarizing that research that's already out there.